Today I'll be presenting this paper published in the journal Oncoimmunology. It's titled Percutaneous BCG Enhances Innate Effector Antitumor Cytotoxicity During Treatment of Bladder Cancer, a translational clinical trial. It's a phase 1 trial. It was made in the US by some researchers in Texas, and the paper at this point is already around 6 years old, but I think it still gives us a very nice glimpse of what the potential of PPD and BCG, um, what the potential is. So um, this paper first starts talking about the use of BCG on non-muscle invasive bladder cancer, especially the high-grade non-muscle invasive bladder cancer, and how it's been the standard of care for this type of cancer for the past decades. But they talk about some research that has been published at this before. This paper was published whereby studies in mice showed that by giving PPD before BCG, you had a larger BCG-specific immune response, which at the same time was correlated in these experiments with better response to BCG. So what the scientists of this paper thought was that perhaps it would be beneficial for the patients to administer PPD before administering BCG intravesically. And what this PPD does, and I'm taking this slide from a previous presentation, is that it primes the immune system. So it causes the immune system to encounter the antigen early so that BCG-specific T cells and B cells, which are going to be activated through this process, will be circulated and ready to mount an immune response before BCG is instilled in the bladder. Now, of course, this is a phase 1 trial, and the aim of this paper was to establish safety of use, and they do manage to study that quite thoroughly. But let's get started with how the study was designed and what the patient's characteristics were, which, I mean, that's a starting point for this paper. So it was done throughout a year, and it had 14 patients in total, although one quit early, so that left us with 13, which is, I mean, an appropriate number of patients for a clinical trial. And they compared these patients, which they called prime, they were the ones that received the PPD, with a control. This control group did not receive any PPD at all before BCG. I'm going to show you a table afterwards, but first I just wanted to show the schema that they followed. So first they chose patients based on their on whether they were BCG naive and the type of cancer that they had. So they had to be high grade, and it had to be either TA or T1. Then 21 days before BCG installation, they placed, oh wait, all right, they placed PPD subcutaneously. And here on panel B, we can see how they determined the PPD positivity and negativity, which is going to play a crucial role later on when we analyze all the different graphs that they present to us. So after administration of PPD subcutaneously, there's going to be an induration or a reaction in the skin. And this is a negative reaction, which is measured as 0 millimeters of induration. And here underneath it, we see a positive reaction, which was measured at 37 millimeters. So that's how they measured PPD positivity after this initial PPD placement. Then they kept measuring this several months afterwards at 3 months and 6 months post initial PPD administration to determine whether, well, for all sorts of purposes, which I'll explain in detail later. But many patients, it happened, became PPD positive even months after the first subcutaneous PPD administration. Then they administered a BCG vaccine. It's not a huge part of the paper. There's not big focus on it. And then they went through the induction cycle of BCG and controls, as I said, 3 and 6 months post induction with a maintenance, with a maintenance course overall. And here we see the table where all the patient information is outlined. Although they didn't include it in the table, it's important to mention only mild adverse effects were noticed on this patient. So most of them were either constitutional symptoms like fever or fatigue, or urinary symptoms, right, which are expected from BCG, like urgency of urination or dysuria and so forth. Only some patients had grade 2 adverse effects, and it's important to mention none of them had grade 3 adverse effects, which, I mean, is a statement to its safety. Then and another important part, which is included in this table, and it's important to mention, is the efficacy outcomes. So we're going to be focusing on PPD positivity, time to recurrence in this column here, and time to progression. It's important to know that of the prime patients, right, which were the patients who received PPD beforehand, 54 had converted to PPD positive by 3 months, and then by 6 months, that number was 69% positive. And as I said, this is going to be important for the results that they got from where they compared the PPD positive and the PPD negative patients. And then the prime patients compared to the control patients, which are here underneath from 1 to 9. These were the patients that did not receive any PPD. They had similar time to recurrence. It was not significantly different. But what it's important to mention is that is the time to progression, as none of the prime patients, so none of the patients that received PPD progressed into further stages of the disease, while 2 of the patients from the control, which represent 22% of all patients, did progress. So that's definitely going to be something important to mention. But then moving on, they measured the urinary cytokines. And what they found out is that priming, so previous to BCG instillation, increases the secretion of urinary cytokines, which is going to be important because cytokines are indicators of inflammation. And this inflammation itself is going to be an indicator of the local bladder immune response. So in theory, the more cytokines that are released, the more the therapy is working. That is the logic behind it. And as we can see here, they measured all these different cytokines. So IL-8, TNF-alpha, IL-17A, IL-2, and so forth. And what's important here is that the prime patients had a higher secretion of cytokines compared to the control patients. And that secretion, as stated by this asterisk right here, was statistically significant. But then they compared the PPD positive, so here in panel B, underneath panel A, they compared the PPD positive patients with the PPD negative patients. And the PPD positive patients are going to be described by this line with the black dots right here. And when they compared the secretion of many of these same cytokines between the PPD positive and the PPD negative patients, they found that the PPD positive patients is at 3 months also had a higher secretion of cytokines, at least for most cytokines. For example, for IL-17A, the information was non-statistically significant. We don't know much about it. But for all other cytokines, the PPD positivity played an important role. But then they
Sorry,
talk about.
I have a question. But when with a prime with a BCG no control, we have patient with PPD positive and PPD negative. We have the two
No,
options.
no, all of the patients that are on panel B are the patients from the prime group. So none of those patients come from the control group because the PPD was not tested on the control group. And that is
Oh,
actually one of
okay.
the limitations of this
Okay.
paper that they state on the discussion. But here, when we talk about PPD positive versus PPD negative, we're
All of
comparing
them.
patients from the same group, from the prime
Okay.
group.
Okay. 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 Interesting.
All right. Now that we've got that out of the way, we can move on to the results that they got when they studied the immune response in PPD patients, and they focus greatly on this type of cell belonging to the innate immunity called the gamma delta T cell, and this is going to be a very important cell for the anti-tumor immunity. First of all, because the cell itself has cytotoxic activities. So using this series of receptors, so from TCR gamma delta to TRAIL and to FASL, it's gonna release performance and it's gonna trigger so it's gonna kill the tumor cells. And it also is gonna have a key role in the interaction with natural killer cells, and that's gonna be crucial for the scope of this paper, since they suggest that this mechanism, so the synergy between gamma delta T cells and natural killer cells, is going to play a key role in the success of BCG treatment in patients that did receive PPD, though that obviously is a little transcending of the phase 1 clinical trial. But what they found, first of all, is that priming is going to increase the release of interferon gamma producing T cells, which they claim are the T cells that have a more specific immune response towards BCG. They measured the interferon gamma production at baseline, 3 months, and 6 months post post treatment, right? Post PPD. They found there was some activity at baseline, probably from some previous exposure to other mycobacteria. But what's important to see here is that patients which were primed before had a much higher production of interferon gamma compared to the control group. And then they found that these effects were decreased or significantly decreased at 6 months post post priming. So they have a limited effect which has a peak that wanes over time. That is what they found. And we can see it here in panel A very clearly. So these 3 asterisks are for high statistical significance. Again, so they found that the increase in interferon gamma, which they measured using a very specific assay called ELISpot. And yeah, they found an increase in interferon gamma production, which later waned, became non-statistically significant at the 6 months part. Sorry. Then on panel B, they compared again the PPD positive with the PPD negative patients, and they found that in both populations, 3 months after priming, interferon gamma production was significantly increased, which was already increased over the control, if we recall this panel A. So what panel B tells us is basically that PPD positivity does not accurately hint at the immune response. So PPD positivity or negativity does not point towards more or less interferon gamma production. But what they also claim is that it is so in many of these PPD positive, PPD negative patients, sorry, also converted to PPD positive at 6 months, so post priming, and that actually could be seen in the table before. But then moving on to panel C, they measured the proliferation of these three populations of T cells, right? They measured the proliferation using of CD4 positive, CD8 positive, and gamma delta T cells. They used a very specific assay, which uses a dye called CFSE, and which becomes more diluted as the cells divide and therefore decreases in intensity. But what we can see here is that prime patients are going to have a much higher level of proliferation. And the one I want to focus on particularly is on this gamma delta T cells, because these gamma delta T cells are going to be a very important point of focus for the last results that this paper yielded. Because then they move on and talk about the cytotoxic effects of these gamma delta cells and whether priming has an influence on the function of these cells, on the cytotoxicity. And they focus on this very specific receptor called NKG2D, which is a receptor found in many immune cells, but it's going to play a crucial role, firstly, in the cytotoxicity of NK cells, as it's going to recognize many of the ligands present in tumor cells, and it's going to be one of the main players in the anti-tumor response. And then it also plays a role in CD8, obviously, but here we're focusing on gamma delta T cells. But I still chose to use this diagram as a function of NKG2D in gamma delta T cells, and CD8 cells is very similar. So it's going to recognize some of the ligands present. I mean, in this case, it's from an infected cells, as it plays an important antiviral role. But in the case of this paper, obviously, we're referring to anti-tumor responses. So what they first did is to study the cytotoxicity of each of the cells. And we can see on this figure, this is figure 4, that they cultured some cells that they took from peripheral blood. They're called peripheral blood mononuclear cells, and they contain many types of immune cells. But amongst the ones in these groups of cells, we can find the gamma delta and the natural killer cells. But it's not just them. It's not exclusively gamma delta and natural killer cells. And they cultured these cells in two conditions. So firstly, they cultured them with BCG, and then later, so they cultured these same cells with only medium. And what they found is that when they were cultured with BCG, we can see here on the y-axis the percentage of dead cells. So the higher a point is on the y-axis, the more cells are died. And we can see on the x-axis here the ratio of culture. So basically, this first number on the left is the number of it's called PBMCs, right? These peripheral blood mononuclear cells. And then the number on the right is going to be a number of tumor cells, because they co-culture these cells with tumor cells. And this code on the title just refers to the type of cells that were used for the co-culture. These are all cells coming from bladder cancer. So they're cultured bladder cancer cells. They have some differences, but they're not really relevant for the scope of this paper. Yeah, the important thing to mention here is that BCG was important to induce cytotoxicity, but then they did some further studying. So um, how exactly does this cytotoxicity work? And this is where two key elements come into play. So first of all, this receptor I just talked to you about, this NKG2D, and secondly, the synergy between them. So the requirement of them being cultured together. And they present us with these very nice graphs to better explain what they mean. So first of all, they analyze the percentage, right, of this gamma delta and natural killer cells in these PBMCs that they took. And this was just to compare two distinct populations, the CD56 dim and the CD56 bright gamma delta T cells and natural killer cells. And they compared all patients, the percentage in all patient populations. But to be fair, this is not terribly important for the scope of this paper, but what I do want to focus on is on these three panels on the right. So the first panel, panel B, is an adaptation of this same graph, but comparing the control and the prime patients. So the higher up in the y-axis a point is, then the more cells are being killed. So the higher the cytotoxicity. We can see here is that in prime patients, the cytotoxicity is higher than in control patients. And this difference, well, at least the data provided for the prime patients is statistically significant, which is not the case for the control. And then on panel C, they utilized antibodies against certain receptors. So they did just normal PBMCs. I think I don't know it off the top of my head, but I think they sorted these cells using flow cytometry, so they are only working with gamma delta and NK cells now, and they used anti gamma delta TCR and anti NKG2D, and then they compared these blocked cells with the normal cells, right? So the receptor, which they showed to be the most important for cytotoxicity, was in fact NKG2D. Because you can see the starkest, the largest decrease in cytotoxicity when NKG2D is blocked, which is represented by this dark black column here on panel C. Then the last panel that they present, which is the information that they use to support the point that to increase NK cell cytotoxicity, gamma delta T cells have to be present. They show us these three lines representing the cytotoxicity of three distinct cell populations. One has NK cells and gamma delta T cells. The other one has only NK cells, and the last one has only gamma delta T cells. When they are cultured in combination, which is represented by this black line here at the top on panel D, the cytotoxicity is much more effective, given that this line is placed higher up compared with the lower two lines. So yeah, I mean that was basic. Those were the results presented by the paper. In terms of safety and tolerability, they determined that PPD is safe to use before BCG, and the adverse effects were very mild and minor. I mean, they range from urinary discomfort to flu-like symptoms. And what they found is that priming led to stronger innate immune responses and to a higher proliferation of specific cell populations like gamma delta, T cells, and NK cells. And that it So both played a key role, specifically when both are present in the anti-tumor immunity. And one last thing which is important to take away from this paper is that they found an early efficacy signal, meaning that the effect of priming was seen more strongly at the beginning of the treatment course. So at this 3 month mark that they set. I mean, they obviously state that their paper has limitations, but they also mention a new phase 3 trial that currently exists and evaluates the use of PPD before BCG. So that could be a topic for a future paper presentation, sorry. So thank you for your attention, and I'll be more than happy to answer to any questions.